the Health, Human Services, Finance and Policy Committee for today, December 17th. We are welcoming Commissioner Malcolm and Dr. Ersman. We're going to have a brief overview of the extension of the governor's orders. I do have some questions around that. And then we're going to make our primary focus vaccine distribution. And so members, I'd like us to keep our questions to those two topics. I am working on, Commissioner Malcolm has a very busy schedule, accumulating questions, and then see if we can have a hearing just to publicly air some of the questions that have been accumulating over this interim. And so with that, Commissioner Malcolm, if you would introduce yourself and begin your presentation.
Thank you, Madam Chair. Good morning, members. I'm Jan Malcolm, Commissioner of the Minnesota Department of Health, and deeply appreciate the opportunity to talk with you this morning. I'm just going to take a few minutes to talk about yesterday's announcement by the governor, give you a little bit of insight into the kind of the theme lines that run through his decisions and on what basis, based on where we are in the pandemic. And then spend the most of the time on the vaccine. And certainly the fact that vaccines are coming is a significant development in our response to the pandemic. As many have said, it's nice to be able to go on offense against this virus rather than just continually playing defense. And we think it's, the future is so much more promising with effective vaccines in hand. We will talk about the distribution plan, what we know and what we don't know about the volume of vaccine that is coming to Minnesota and on what time schedule, and how that is being allocated and prioritized. But we need the public to understand this is a really big deal, that we're moving into this phase, that the vaccines are effective, and that this is going to take many months before the vaccine is widely available, that this will be a closely managed process by the feds to distribute the fairly modest supply that's going to exist for the first weeks and even months until there is a more robust supply that's available to the general public. But it's really important that you understand and the public understands kind of what that process is, why the priorities are what they are. But from the perspective of, how this factors into the state's COVID response, from the governor's perspective, this is a very significant development in how we should be thinking about how we get through these next few months. The next slide, please. So here, this chart in the upper level there is just really, I think, important for you to understand kind of the context. And you've seen this in presentations from us. These data are on our website. The really kind of remarkably stable course of the pandemic in Minnesota. Not that we weren't growing, but we were growing at a pretty steady pace for up until the end of October. We certainly did have ups and downs, and we started seeing a concerning march upward in early September, as you can see there. But where the line goes vertical, that's when we really hit that tipping point and went into exponential growth, when the rate of case growth and the degree of community spread really tipped us into that, sort of out of control spread by our metrics and national metrics. And like the whole upper Midwest, our neighbor states hit that exponential point before we did. And just given the reality of population movement between states, it was pretty inevitable that we would see the same here. So just as we were nearing the top of that big rise, and then we saw what was happening to hospitalizations, the admission rates, the tightening of hospital capacity, kind of the double whammy, if you will, of rapid, really rapid case growth, and a lot of healthcare workers being not able to be on duty due to either their own illness or often quarantine from exposures, or taking care of family members, childcare crises and the like. So it was that kind of that combination of rapidly rising cases and falling capacity from a staff perspective, not about the beds, not about the equipment, but about the staff, that really led the hospitals to plead for some relief from that rapid rate of growth. And that was really what, in the main, triggered the pause to begin with. And we're grateful that it has had an effect. Minnesotans have responded. So the 4-week pause, as you know, really tried to focus in on just given the prevalence of the virus and the huge amount of community spread, what are the settings in which the spread was happening that we could reduce by restricting those types of gatherings. So as you know, the executive order that is expiring on Friday night limited social gatherings both in our own homes and in public settings as well, of a social nature, or of a nature where people gather for extended periods of time in closer proximity, particularly those places where masking is not, it's just not a part of what you can do, for instance, in bars and restaurants when you're eating and drinking. So that was the pause. And the next slide, please. And I think that prior slide showed, that we are coming down the curve, and that is really terrific. And I'll show you some of the risk measures we track in a minute. So there's no question that Minnesotans have responded, and that we are in a better place now than we were a month ago. But we still are at very, very high levels of viral activity all around the state. And the hospitals tell us that they are grateful for the slowdown, for the respite, but they're still quite concerned. They're still running very full, as they always do, in terms of just the running their facilities efficiently. They tend not to carry a lot of excess capacity ever. But when we're in a situation where the need for hospitalization for a whole bunch of significant issues, significant health concerns, and we know that there has been an impact of delayed care for a number of reasons. So the people in the hospitals now for heart disease, stroke, cancer, and the like, some of that has been complicated by just the disruptions in care that COVID has meant. But the fact that a larger and larger percentage of their capacity is being filled with COVID has just put a pressure on the whole system. So the hospitals are grateful that they're trying to be able to give their staff that are exhausted a little bit of a break, but they're very concerned. They're still running very close to the edge. Few beds that are available on a day-to-day basis to handle the surge, and the way they're handling it is by collaborating in unprecedented ways and really managing bed capacity as a statewide resource through the State Emergency Operations Center and the Critical Care Coordinating Center, or the C4, that is really a wonderful and rather unique Minnesota aspect to the response. Next slide. So let's talk about these risk measures. These are some pretty important slides here and really goes to based on what are we making these decisions, and why continue the pause at all if we're making progress. And this first one is community spread, the percent of cases with no known exposure, which frankly, when you're at community spread at this high of a level, it makes control of outbreaks nigh unto impossible, because people have no idea where they're being exposed. It becomes harder and harder and harder to attribute infections to specific settings. I know we get a lot of challenges about, our outbreak data and what story does that tell? And we continue to say the outbreak data is very valuable, but it is increasingly not an accurate picture when you're at community spread at this level. We set the risk levels at, as you see here, anytime we're above 20% of cases with no known exposure, we consider that to be a real caution indicator. and above 30% to be a high risk indicator or a measure that spread is not controlled. And these are measures that we compare ourselves to other states, and certainly the White House in their weekly reports to the governor calls out these same metrics, and Minnesota continues to be in the red zone from the White House's perspective as well. Just to update quickly on, if you'd go back one, Lisa, the current, so we keep track of these stats on a daily average based on 7-day rolling average. So our current, as of the most recent period, we are currently at 36.1% community spread on a 7-day rolling average. Cumulatively, can you hear me?
Yes.
Yes.
Sorry, my screen just went dark for some reason, so I apologize that I can't see or hear you. So I'm gonna try to get back in so I can see the screen. But just talking about community spread, so we want to keep that number low so that the value of contact tracing and epidemiological investigations can help us to point more specifically to where are the opportunities to intervene to control the spread. But when we don't have that, it just becomes increasingly difficult to really focus our mitigation efforts. Cumulatively, 25% of the cases in total over the whole course of the pandemic have come from community spread of no known origin. Currently, though, the biggest share of the cases is actually, it's worse, if you will, than community spread of no known origin. It's data that are missing, that people aren't responding. We can't get to them because of the volume of cases, or they're not responding when we try to do case investigations. And so the missing and unknown piece of the data is also what's sort of confounding at this stage of the pandemic. And that is absolutely not unique to Minnesota. That is happening all over the country, and part of why CDC is kind of advising us and giving us sort of some context for how to adjust the way we do case investigation and contact tracing at this particular stage when everything's on fire at the same time, nationwide, basically. Next one, please. So even more important, I would argue, than community spread, which just kind of goes to the challenge of managing, the case growth and hospitalization rate really are the things that are, I think, are the most important indicators to keep our eye on. The daily new cases per 100,000 residents, again, a well-used national comparative metric. This is the caution level is 5 daily new cases per 100,000 residents. The high risk level is 10 new cases per 100,000 resident. We peaked out at almost 120 new cases per 100,000 residents, which put us at the top of the chart nationally in terms of population-based spread. And you can see again on this graphic how significantly we've come down since that time. As of now, we are at 73.1 cases per 100,000. But I'll just point out, and you can see it visually on this chart, how far above the high risk level we still are. And the same is true with hospitalization rates, way above the high risk threshold, which is 8 admissions per 100,000 residents on a 7-day rolling average, coming down very nicely, but still, many multiples above where we need to be to feel like we are in a better spot. And of course, the mortality rates, the death rates that we have been reporting day after day are truly heartbreaking. We've been over 60 deaths per day average for almost 2 weeks now, and today again reporting another 82 or 83, I think, deaths again reported to us yesterday. And that we know is a lagging indicator that first you see the cases go up, a couple weeks later you see the admissions go up, a week or so later than that you see the death rates go up, and the same is true coming down, that cases will fall, then hospitalizations, then deaths, and we expect to see that pattern continue. But those death statistics are really pretty striking. The governor has mentioned yesterday what this means. This rate of deaths means that in a single week, more people are dying of COVID than die all year on our highways in traffic accidents. Just for context, help people put these numbers in perspective. The next one, please. And I think we can stop there, actually. Oh, no, I'm sorry. We should go ahead into the next couple of slides that talk about what the continuation or the amendments to the executive order were. So advance past this one, if you will. I want to get through this. And one more. So I think that this is all about trying to figure out what, given that vaccine is coming, what do we need to do to keep our metrics going in the right direction and get to the point where the vaccine can really do its work as effectively and as quickly as possible. A vaccine, in the midst of of case growth that's this high, is going to take longer to have an impact than if we can bring these case levels down. This was not part of the executive order, but a part of the governor's announcement, and his priority is to say, for all the reasons that we know how important schools are to our kids, to our families, to our economy, there's just a critical role that schools play, especially for our youngest kids at these critical developmental ages. It is just a priority to getting kids back into the classroom. So again, not part of the executive order. This is part of just updating the safe learning plan and the education guidance and the health guidance for schools, trying to make it, trying to give schools more support to be able to get more elementary school kids back to in-person learning by January 18th. If they can implement some enhanced mitigation strategies. So the key ones there are offering every 2-week testing for staff, asking staff to wear not only masks, but face shields. And we'll also be, looking to see, how we can improve ventilation and just helping schools to continue to use best practices at putting kids in pods, keeping the pods, separated, just all the things that we know can work to reduce spread in these environments. So that we may have a conversation about the whole school strategy. Madam Chair, that might be a good topic for a focused discussion.
Thank you. And we do want to get to vaccines. So how many more slides do we have?
Just a couple. So that school piece was just a kind of an important context. That's kind of what we're trying to really, the school plan can't be successful unless, the level of disease in the communities does continue to come down. So what the governor wanted to do, though, was to create more opportunities for safe gatherings in smaller groups, inside and outside, but also outdoors, opening up some venues and events. We can come back to the details if you want, Madam Chair, but so liberalizing the guidance around indoor gatherings and outdoor gatherings, but in a very kind of measured way. And same with outdoor events and entertainment. Next slide, please. Gyms and fitness studios opening at reduced capacity with increased physical distancing and folks always wearing masks. Youth and adult sports, practices, but not games, resuming January 4th. And I think from January 18th and on, those sports will return to being governed by their respective sports authorities. Next one. And then bars, restaurants, and breweries remain closed for indoor service until at least January 11th, but allowing for outdoor service for those that can do it, and understanding that that is not going to be a realistic option for a lot of establishments, but for those who can, it is an avenue. And certainly we want to continue to support these businesses with takeout and delivery and gift certificates and the like. And that economic relief package that you all passed earlier this week is really significant. I think that is it. That's all I need to cover. Yeah, so we're just going to leave it there, and don't know if you want to do any quick questions, Madam Chair. Just move.
I do have some, and I know there's a lot of questions about this. I'm going to ask members to accumulate questions. Happy to forward them through Bailey. For example, I got an ask, well, if youth sports are open, why can't my daughter's swim team practice? Pools are closed. Lifeguards can't get trained, pools are closed. So there's those kinds of questions I'm going to ask. If they're really specific, that we accumulate a list from the committee. Bailey and Ryan will work on that. One of the things that I'm going to disagree with you on, you assign the peak. If you look at this image, the peak positivity and peak cases occurred well before the order was put in place. And so now some of us are wondering, why is the order continuing, the pause order continuing, when the decline started earlier? There's something happening that's causing a decline in cases and positivity outside of the order. And we've seen other states that have followed similar patterns that didn't have a statewide pause. You know, we know that there are actions that need to be taken to relieve the stress on healthcare workers, but when we see a peak that occurs before the pause order was put in place, it certainly raises questions and concerns about why we're continuing when the epidemiological trend was downward before the actions were taken. Can you help us understand?
That's a very interesting chart, Madam Chair. I hadn't seen it visually like that, but I think we noted that that yes, I think as some of those numbers started to become much larger, the reporting, the public awareness of the fact that something had changed and that we were in a very different position, we think people did start re-looking at this and really taking to heart the fact that the danger levels were increasing, and people started to moderate their own behavior. I think that we would agree with that. I think the reason for the pause order was to just sort of solidify that, make that more of sort of a statewide, kind of norm and expectation, and reinforce the importance of really reducing those contacts. So, and we can certainly, and I'm sure we will, be talking for a long time about what to learn from all of this. But I do think that that the rate of decline, we'll just never know what would have happened to that pattern without the pause order. We've seen lots of kind of peaks and valleys, so we'll never know would that decline have continued without the order or not. It certainly the reductions did accelerate, as you can see, past the point of the order. So whether we would have plateaued or come down,
and then the line starts to normalize again over here. So we should take a look at some trend lines there. And I also have a question. Staffing was the primary driver of the crisis at our hospitals. I mean, obviously an increase in hospitalizations, but also staffing was a significant primary driver. I know that there have been a number of requests for changes. And if we're going to listen to the hospitals on, we need to shut down bars and restaurants, then I think listening to them on, they wanted some liability protections in place. I worked on that significantly in the spring. We couldn't make any progress. And I know the governor considered an executive order that didn't meet the needs of the hospital association. And I also know that there were requests for changes to helping children be in person for childcare and for learning so that staff wouldn't have those concerns. And the third thing that I thought was quite significant, changes to the requirement for staffing so that if you were exposed, asymptomatic, hadn't tested positive, you could continue to work with only COVID positive patients. So if we're going to listen to the hospitals on shutting down parts of our economy to relieve the stress on them, why aren't we doing these other things? And some of these clearly are outside your purview, but why aren't we doing these other things to gain us a few more hours for a hospital shift when the healthcare professional doesn't need to worry about their child being in school and managing distance learning? So I'd like some clarity as to why we are picking and choosing what we listen to from the hospitals.
Madam Chair, I think we have received a lot of specific requests from the Hospital Association, and we've made a lot of progress on a lot of the things that they've suggested, and that work continues. It's an active, ongoing dialogue about guidance, about childcare supports. So I want you to be assured that that those things continue to be discussed all the time, and we could probably get you a summary of exactly what they asked and how we've responded.
And I would appreciate the response. I've been in conversations with them since October about what they needed. There was specific action on an executive order in November. I participated in conversations. The executive order on liability didn't meet the needs of hospitals and doctors. They were trying to get staff over from ambulatory surgery centers to provide support in the hospitals where they were in the middle of the crisis, and that was not able to be resolved. And so I think we need to have a deeper conversation when the governor stands up and says, I'm going to listen to the hospitals. Then let's be transparent about what the hospitals are saying to him. I fully support that we need to help our hospital take the pressure off of our hospitals. They are making, day-to-day decisions on heart bypasses based on ICU capacity. Staff at our hospitals have never seen so much death. I completely understand that, but we can't ignore the things that could at least give them some staffing relief, in addition to trying to reduce the hospitalizations. And so I appreciate that. And then on schools, the data that was available in July, August, September indicated it was safe to return in person. And so now it feels like there's been enough pressure building from families that we're going to emphasize putting children in particular back in school in person. And so I just can't say enough. Our hospitals need this, our families need this. The mental health of our families has been devastated. So I hope beyond just clarification of the Safe Schools plan, that there is actually some significant pressure to get elementary students back in school. The third thing, I asked the governor this politely. I'm going to ask you politely. Availability of the vaccine. How do you define that? Because the statements have been, this is a bridge to availability of the vaccine. So I asked, is it the 1A tier that gets cleared? Is it a percentage of herd immunity? What can we watch for that tells us there's some availability standard being met?
And I think that's a great segue, Madam Chair, into the vaccine topic. I think Chris will address some of that. And on your other 2 points, I can just say, I hear you loud and clear. We will get you kind of an update on what we're in dialogue with the hospitals about on the staffing front and on the education front. Couldn't agree more. It's a huge priority. I think the data have been clear for a while, but they're getting clearer about risks to children and children's risk in transmission, and the fact that that is very different for kids under 10 than over 10. That data have solidified. What has been, I think, a little harder to get our hands around is the impact on staff. And again, the major threat to getting kids in person is is the availability of teachers to be able to be in person. And that has everything to do also with these rates of case prevalence in the surrounding community. But I appreciate your points very much. And I know I took a little more time than you had planned for this part, but I think you're right. It's all related. So with that, maybe we can go to Chris.
Thank you. Let's go to Chris. And I'm sorry, members, I didn't have my participants open and I didn't see your hands up. Senator Kiffmeyer and Senator Matthews, if you have a really brief pointed question for the commissioner, or if it's something that we can get to Bailey. Lisa has been doing her best to get all of my questions answered. And so if it's something you can get to Bailey, but
I do have a quick question, just
Senator
a quick one.
Kiffmeyer, yeah.
Thank you. Commissioner, one thing is information, and I think on the vaccine area, I know that on the facilities, you have number of cases, so on and so forth. Could you add to that the number of vaccinated in the facility separated out by staff and by residents?
Okay.
I think families would appreciate having that, and we would as well. Thank you.
Thank you. And Senator Matthews?
Thank you, Madam Chair. You kind of asked my question on the vaccine availability because I did not see the announcement making sense from the governor's office earlier this week on this. And I have questions about how he presented this extension of the pause. And my position on this is clear, that this is an affront to our constitutional system. I won't get into that. But the governor stated again in his address that, this pause now extends into January, and I don't see vaccine availability coming in January at the levels that you've talked about. Then the governor said that, and I think he quoted you, Commissioner, saying that you're concerned about a February surge. And so I'm sitting here looking, if I'm a business owner, the ones you've been shutting down, I spoke with one in my district this morning. If you're not likely going to open in January, if the availability is not there, and if you're not going to open in February, if you're concerned about another surge, why don't you just tell Minnesotans right now that we're closed till summer and stop dragging this out week by week by week?
Madam Chair, if I could respond just really briefly to that.
Yes.
Understand your question, Senator, and I don't think we're saying that opening decisions are contingent only on the vaccine supply. I think what the governor said is we're encouraged by the current trends. If these trends hold and even start to improve more rapidly, that will be a very good sign that might allow more opening. But I did point out, how far we have yet to come to get down to those truly safe levels. I think the governor is quite sincere when he says he wants to see, kind of what happens over the next couple of weeks and what the situation is at that time. I think what we've seen from other states, from our own experience, is that things can change, and they can change fairly quickly. So there is no crystal ball that allows us to say, where we're going to be on January 11th or January 18th or February 1st, but that we need to be responsive to what we're learning, to how things are changing, and I think his priority has been clear to be opening up more things as we believe we can, and do it in a safe way. So I do want to reinforce that none of these decisions have been, are made out into the future. It's a very dynamic situation and an ongoing conversation.
Thank you. And we're going to have you move forward into the vaccine rollout presentation. I thank you, Commissioner, for always making time, but let's proceed. I believe Dr. Ersman is going to do the next part of our presentation.
Yes, I will get started. Thank you, Madam Chair. So next slide. Just want to remind people that because we anticipate limited vaccine supply, at least initially, that we are looking at a phased approach to vaccination. Next slide. And as we anticipate additional doses coming on board, we're looking that as more doses are available, we can expand the groups that receive vaccination and can expand to the general public right now we're focused on, oops, no, that's right, Lisa. Right now we're focused on phase 1A. So you can see phase 1A is a decision that has been made at the federal level by the Advisory Committee on Immunization Practices. It includes healthcare providers and long-term care facility residents. Phase 1B and 1C are projected, but they have not been voted on. So that is just a projection at this time. Next slide. So in Minnesota, we're looking at making sure that vaccine can be distributed across the state. And in particular for the Pfizer vaccine, which I think you're all familiar with, has a incredibly rigid storage and handling process, has to be stored at -70°C. So we're looking at using a hub and spoke map. The hubs are the circles and the spokes are the triangles. So we have 25 hubs and 118 spokes. And you can see that just about all of our hubs have the ultra cold storage, which is excellent. And then they'll be able to distribute from that hub to the spoke sites. Next slide. We were asked about the number of providers who've been enrolled to vaccinate. You can see that we have 589 providers enrolled at this point, and you can see by the type of provider and then the number of providers registered by county. This information is on our department website at this time. Next slide. When we anticipated the ACIP guidance on the phases, we did pull together a Minnesota Vaccine Allocation Advisory Workgroup. The intent of this group was to review the ACIP guidance and add greater granularity for Minnesota. And as you'll see as I go on to describe what ACIP provided us with, this was very much a necessary group, a group that helped inform our decision-making and our allocation. We tried to make sure that we had diverse membership and broad membership on this group. Next slide. One of the things that we did talk about was how vaccine should be allocated. Should it be on a purely pro rata basis, or should there be some consideration for social vulnerability? And social vulnerability index is an index that CDC developed using 15 variables from census data. And you can see the broad topic areas: SES, household composition and disability, minority status and language, housing type, and transportation. What we know from COVID already is that counties with greater social vulnerability were more likely to become areas with rapidly increasing COVID incidents, and that social vulnerability is associated with higher COVID case fatality. So that was information that we were considering in making our allocation decisions. Next slide. Oh, you know what? I'm going to go back, Lisa, sorry. And so what the group decided, there were several options. You know, should we just do a purely pro rata allocation? Should we do a pro rata allocation with some accounting for social vulnerability? And the options that the group had were 90-10, so 90 pro rata, 10 social vulnerability, 80-20, 40-60. And the group really focused on the 90-10, 80-20, and so we ended up recommending an 85-15 split for this particular population. There was an acknowledgement that as we move to vaccinating the general public, that it may be that the social vulnerability index should play a greater role, but because this initial vaccination was really employer-based, that was not as necessary. Next slide. So ACIP, this was the guidance that they provided. For healthcare personnel, it's any paid or unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. And long-term care residents, it was adults who reside in facilities that provide a variety of services, including medical and personal care to persons who are unable to live independently. So that was as granular as we got from ACIP. Next slide. So we looked at the fact that we would not have enough vaccine at all to deal with that large group. And so how could we sub-prioritize? So we had certain risk criteria that we looked at: the risk of infection, the risk of severe disease and death, the risk of transmitting to others, so the potential to transmit to someone in your work setting, as well as if you're living in a congregate care setting, to transmit to co-residents, and then the risk of negative societal impact, which included for healthcare workers the fact that, you know, part of the drive for the pause was the fact that our healthcare systems were overwhelmed. Next slide. So these are how the priority groups were divided up. In the first group that we're working on right now, it's really focused on personnel who are caring for COVID patients. So dedicated COVID units, intensive care, emergency departments, COVID urgent care. For long-term care, we're looking at our most vulnerable, those living in skilled nursing facilities and nursing homes, and the people working there. We include EMS, as well as COVID testers and community vaccinators. And then on the resident side, again, it's the skilled nursing facilities and nursing homes. Next slide. Then in the second priority group, we move to, in the acute, again, we're focused on the acute care setting, but all personnel providing direct patient services or handling infectious materials. As we move to the long-term care, we shift to assisted living. And just note that in Minnesota, we use the term assisted living, but technically we're referring to housing with services with an arranged home care provider. So we wanted to use both the common terminology as well as the language that is in statutes. Then we include urgent care and dialysis centers. And then in the third priority group, the next slide, it's all remaining healthcare providers. And then in terms of long-term care, it's adult residents in intermediate care facilities for individuals with intellectual disabilities and other adult residents living in residential care facilities, whether it's for physical or mental disability or elder, that would be the final group. Next slide. So as you know, last week, the FDA approved the Pfizer vaccine. So that was great. Next slide. I'll just go over these quickly. The ACIP also voted to approve the vaccine last Saturday. And in both of these cases, I'll just indicate that VRBPAC, who is meeting today on Moderna, the Vaccines and Related Biologic Products Advisory Committee, and the ACIP, the Advisory Committee on Immunization Practices, each of these bodies will vote to make a recommendation, but then before it is real, if you will, it needs to go through the parent agency. So when VRBPAC voted on last Friday, then it was, or excuse me, last Thursday, then it was Friday late that the FDA approved or accepted that vote. And the same thing with ACIP. They voted Saturday, and it was Sunday that CDC approved that vote. Next slide. So I was asked to talk a little bit about how mRNA vaccines work, or messenger RNA vaccines. So typically vaccines put a weakened or inactivated germ into our bodies to trigger an immune response. With COVID-19 vaccines, the vaccine gives instructions to our cells to make a harmless piece of what's called a spike protein. It's found on the surface of the virus. And this protein is what will trigger an immune response. So the vaccines are administered in the arm, and once that mRNA gets inside the cells use them to make the protein piece. And then that piece, once it's made, the cell breaks down the instructions, it gets rid of it. So there's no chance that it doesn't get into your DNA, nothing like that. All it does is it tells your cell to make this spike protein. And once that spike protein is displayed on the surface of the cell, our immune system responds to it and says, whoa, that is not normal, that's not usual, that's foreign, and will begin to develop antibodies. And so at the end of the process, our bodies have learned how to protect against future infection. So we're basically using our own biology to develop the protection. And what it is by creating this protein that is found on the surface of COVID or the SARS-CoV-2 virus. And then our cells are kind of programmed to make that same protein. And when our bodies see it, they, attack it and respond, and we develop antibodies. So that's just the process of how that works. So it's a great new technology to provide immunity. Next slide. I wanted to just tell you a little bit more about the Pfizer vaccine and just let you know for the clinical trials that were used, what did that look like and who was included. It was about roughly a 50-50 male-female split. You can see 82% white, almost 10% African-American, over 4% Asian, and then less than 3% from other racial groups. About a quarter of the participants were Hispanic or Latino. 1 in 5 roughly were greater than 65 years of age. And you can see that they did look at comorbidities. As we know, individuals with underlying health conditions are definitely more likely to have complications and more severe disease. So they did specifically look at that. And then just to let you know where the participants came from. 3/4 were from the US, and then also Argentina, Brazil, and South Africa. Next slide. In terms of the effectiveness of the Pfizer vaccine, it's great. The effectiveness 7 days after the second dose was 95% in people who had never had COVID. If we look at people who had COVID or didn't have it, so both people who had the infection and not, it was still over 94%. And when they looked at the various demographic subgroups, they did find the same robust efficacy. Next slide. Just wanted to point out that we saw very good effectiveness even in the older age groups. Typically, we tend to see our elders having less robust response to vaccine just because our immune systems as we age are not as effective. But you can see here that overall there was a 95% level of effectiveness. And even when you went to the 55 and older population, it was almost 94%. And then you can see the breakout that I provide there for the other groups. And the reason that the efficacy is greater than 70 or is 100% at greater than 75 years is because there were no cases in the vaccine group in that age group. Next slide. I do want to acknowledge the role that the vaccine does or doesn't play. In this case, we don't know in terms of asymptomatic infection. The endpoint that was used in the clinical trials was disease. And so we can't impact or we can't assess with the data that was collected the effect of the vaccine against asymptomatic infections. Now, certainly biologically, it would make sense that if a vaccine can prevent symptomatic infections, that likely it would do the same for asymptomatic infections. But to be precise about the data that we have and the data that's been gathered, we have to say that additional study will be needed to look at both the role that the vaccine will have in preventing long-term effects of COVID, as well as the role that the vaccine will have in preventing both virus shedding and transmission in people with asymptomatic infection. And so because of that, that is why we're saying that even as a vaccine is becoming more and more available in the population, we will still need to be masking and maintaining social distance until we get to a certain level of coverage in the population. Next slide. We've been asked a lot about the effectiveness of a single dose. The clinical trials did not have a single dose study arm. So we know that they collected information about effectiveness after the first dose. So there is some protection, but they have no data for anything longer than 21 days because everyone received a second dose. So the bottom line is that we don't have information to really speak to that a single dose, and people need to get 2 doses. Now, over time, there'll be more and more information available. And so that will inform future decision making, but right now we need 2 doses. Next slide. And the other question that we get asked a lot is the duration of protection. Obviously, different vaccines offer a different duration of protection. You know, you get the measles series, you have lifelong protection, you get tetanus, you have to get boosters every 10 years, and we vaccinate annually for flu. And at this point, we don't know what that duration of protection will be. And that is, again, something that will be continued to be monitored, and will, you know, provide information as we learn it. Next slide. The safety data was really good for this vaccine. So the safety data on 38,000 participants at 2 months did not raise any safety concerns. The most common adverse reactions were the typical injection site redness and soreness. So that is what we call a mild adverse response, and then moderate. And that was fatigue, headache, muscle pain, chills, joint pain, fever, kind of that general feeling punk is what my parents used to call it when we didn't feel, we kind of felt not that good. You feel punk, and basically that is just your body's immune system responding to the vaccine. And people sometimes feel this way following an influenza vaccination, and we say actually that's a great thing. It shows that your body is responding to the vaccine. In terms of severe adverse reactions, they were quite rare. They were more frequent after the second dose and tended to occur more in younger participants rather than older participants, which does, I think, speak to the immune response as we age. Next slide. And in terms of the frequency of serious adverse events, it was low. There were no differences between the vaccine and the placebo groups, so that was good. In terms of hypersensitivity adverse events, it was numerically higher in the vaccine group, but not necessarily statistically different. I think you're probably aware that there was a hypersensitivity event reported in a vaccine in Alaska. The guidance that we've put out does indicate the importance of checking individuals before vaccination for any history of a hypersensitivity event, for allergies to any of the components of the vaccine. So that is part of the protocols and being prepared for those events. But the good news is that it was quite rare. And there were no specific, overall, the FDA determined that there were no specific safety concerns identified by age, race, ethnicity, medical comorbidities, or prior infection. And so that was also positive. Next slide. Just to let you know that there will be ongoing safety monitoring, just like we do for every vaccine. There is what's called post-approval monitoring, and there are multiple national systems in place that are intended to identify any sort of signal and evaluate whether that signal is related to vaccine or just a coincidence. And these signals are intended to detect kind of anything. And so if we do detect a signal, that's a good sign that the vaccine is working. And I think you may be familiar with the fact, since I've talked about vaccines to this committee before, that these systems haven't been in place for more than 30 years. Next slide. There is a smartphone app that has been developed, and so individuals who are vaccinated can download this app, and it allows them to provide feedback on how they're feeling post-vaccination. So it's a health checker that this has been developed by the federal government. Then I think that you're probably familiar with the Vaccine Adverse Event Reporting System, a national system that collects information from healthcare, from manufacturers, and from the public to monitor adverse events after vaccination. And then the Vaccine Safety Data Link, which is 9 health organizations, including health partners, that will do surveillance and research related to anything that's identified via VAERS. And then CSA are 7 medical research centers that provide expert consultation. So if there's a unique situation that someone has a question about, a particular patient related to vaccination, CSA is a way to get those questions answered. Next slide. I did want to acknowledge that we have prioritized vaccinating in long-term care, although I want to be clear that ACIP added long-term care to the list of groups available. So we had been planning for months, and long-term care were not part of that planning. And so we have had to really scramble to get all of that into our first round of vaccination. So just to be clear on that, that was added December 1st. And we've been planning since August without this group in the first year. So long-term care facilities had an opportunity to participate in this partnership program through the federal level or go through local public health or other pharmacies. And 210 of our facilities chose to participate. Next slide. I just see I'm available till 11:15. I actually think I'm available till 11:30, but you guys probably aren't. So what we're going to be doing is we'll be using the Moderna vaccine when it becomes available. The reason for this is it doesn't have the crazy storage and handling, and it can be allocated in 100-dose increments, not the 1,000-dose that Pfizer requires. We push the button for the partnership program with the feds because it does take 2 weeks. So we expect that the week of the 28th, that program could start working. And then we are also, we have partnerships to provide vaccine to the 89 facilities that did not participate in that program. And so they'll be using the Moderna vaccine, and we hope that can start the same week of the 28th, if not before. Next slide. Just wanted to let you know our training plan. We released a 20-page provider guide and on-demand video trainings on Tuesday. There's live training that's provided by our staff, started yesterday and will go through Friday. Pfizer is conducting storage and handling training twice daily all week, again, because of the very unique requirements of that vaccine. Our provider hotline has been staffed up, and there is a requirement that providers attest that they have completed the training prior to vaccinating, and once attested, they're greenlit to vaccinate. And we have about 70 providers at this point that have attested, so they could start vaccinating when their vaccine becomes available. Next slide. In terms of the vaccine arrival timeline, Pfizer began processing the first orders last Saturday. 7 pre-positioned sites received vaccine Monday and Tuesday of this, well, actually Monday through Wednesday of this week. So that's 7,000 of the 46,800 doses. What kind of, I think, gave everyone a bit of a hiccup was the VA receiving their vaccine. They are receiving vaccine not through the state allocation. There's a completely separate federal allocation for Veterans Administration, completely separate for Indian Health Service, completely separate for Department of Defense, for the State Department, and for the Bureau of Prisons. And so that vaccine coming in as some of the first doses made it seem like there were more vaccine in the state than there really are. The rest of the sites will receive their vaccine today and tomorrow. So that's the 18 sites, the additional hubs. And then the distribution to the spokes will happen when the spokes are ready to vaccinate. Once the vaccine has been unfrozen or thawed, you have 5 days that it can be used. Once it's been reconstituted, you have 6 hours. So we obviously don't want to distribute vaccine from the hub to the spoke until the spoke is ready. Next slide. In terms of tracking the doses that are given, we do have a system to track how many doses have we received and where they've been shipped. And that will be on our website eventually. Providers are required to provide doses administered to us within 24 hours. Because there are 2 doses needed, We can track that, although our recommendation to providers is that they schedule that second dose at the time of the first. And the software system that we've made available for our local public health and tribal partners, PrepMod, does reminders for second doses. So that's available too. The patient will receive a vaccination card when they're vaccinated, and we're also encouraging the patient to take a photo as a backup of documentation just so they have that. One of the things I know that you're very interested in is staff and residents of long-term care. We're working to see how we can get that information. Right now, when information comes into MIC, there's not a variable that would include, like long-term care residents. So that's something that we're looking at. The federal government is considering using NHSN, which is a federal system to collect that data. But long-term care has not been, they're not as familiar with that system as acute care is. And so we're looking at all of those things so that we can be providing granular data in a manner that the public wants to see, but also that is not, we don't want to overburden our facilities either. So we're working on that. And then I know I was asked, what are we sharing with the feds? We are only providing date of birth and county on any particular person who received vaccine. That is all the information that we share with the federal government. Obviously, they need to know when vaccines are administered, but we are not providing anything identifiable. Next slide. Then just to kind of close out, as the commissioner's slide showed, we have hope. Vaccine is here. However, there will not be enough vaccine for everyone who wants it initially, so this is going to take a while. And so we're immunizing for impact. We're focusing on staff in healthcare and our most vulnerable. And the hope is that by getting those individuals vaccinated, that takes a great deal of pressure off the system. And so that's where our focus is now. And I think the last slide just says thank you. Yep. So I'll turn it back over to you, Madam Chair.
Thank you. And let's start with questions. Senator Nelson, Senator Marty, Senator Matthews. So I'll go through my usual 3 in a row routine. Senator Nelson, please proceed.
Thank you, Madam Chair. And Dr. Erzman, thank you for the great presentation. I just have to take a quick moment, and really we are so thankful for those immunologists, the researchers, the immunologists, the epidemiologists, all those folks who developed these vaccines in such a short time. I think it is a moment in history that we can all look back on fondly, to think that everyone worked together so hard, really across the world, to get these vaccines out in a timely manner. And that is something to rejoice in. My questions, Chris, are about the vaccine allocation. And if you want to just kind of pull up some of those slides, my question has to do with just a couple things. One, I visited with the commissioner last evening about getting some kind of like runs. In the education world, we call them runs, so we can get a view and a see for where vaccines went, especially as we know that there's a shortage now as we're waiting for more vaccines to come out. So I believe she said you would have those numbers, or could get those numbers for today, kind of those runs about what facilities got vaccines and how many they got. It was a little late last night when we spoke. Were you able to get that information for today?
I don't have information by facility, but I can give you a bit of an explanation that may help. So yeah. The vaccine is allocated, as I said, the work group, the allocation work group decided that it would be allocated 85% based on pro rata need, and then 15% based on social vulnerability index, which at that level doesn't make a huge difference across the regions of the state. All healthcare facilities submitted to their regional healthcare coalitions what their need was, and that would be, the number of healthcare providers that they had. In this first phase, the allocation was based on acute care. So a facility like Mayo, which is a huge facility, but has a lot of outpatient staff would not have been getting their pro rata allocation based on their total staff, but rather their acute care staff. And when we look at acute care staff across various facilities, that tends to be more consistent. And so the allocations were made by region, again, as based on the pro rata, and then within the region were allocated, to providers based on their pro rata need. So that was how the allocations were made.
Thank you. And is that a metric that you can send? I think I understand the concept of what you're saying, but if you could send that metric as well, that would be really, really helpful as we go forward. And then my other question had to do with the social vulnerability index. I realize the CDC developed that, but I don't know if the CDC required that we use that social vulnerability index in determining a vaccine allocation. Can you just provide a little bit of clarity on that, please?
Sure, Madam Chair and Senator Nelson. No, it's not a requirement. It's definitely recommended. I think, as you know, the White House asked both the National Academies of Science and the ACIP to weigh in on an ethical framework for vaccine distribution. And part of that included social vulnerability and that type of an assessment. And so that was considered best practice in looking at how we allocated vaccine. And so that's what's done. So it was not required, but it was definitely recommended and considered best practice to include that in your decision making.
And so then would it be accurate to say that the vaccines, the amount of vaccine able to get right to the critical workers is reduced by 15%? So my question is, well, or as you're looking at that social vulnerability index, is it those who are vulnerable that are in those classes like that 1A phase, those critical healthcare workers that are working with COVID patients and exposed to COVID? Is the social vulnerability index part of those workers then, who are those critical workers, those 1A workers? Or is it in addition to?
No, Madam Chair, Senator Nelson, no, these vaccines are only for the phase 1A critical workers, and all the social vulnerability index does is look at the regions of the state and says, does a particular region have greater social vulnerability, and should their pro rata allocation be adjusted at all? But no, this vaccine is only for healthcare workers, so 100% of the vaccine is going to the populations for whom it is recommended. It's just that the allocation, 85% of the allocation is based purely on the number of healthcare workers in a region. And so if we got 50% of the need, then the regions get 50% of their need. And then 15% of that is looking at what regions have greater social vulnerability. And we allocate that vaccine, again, to all the regions, but based on social vulnerability. And it's all for the phase 1A healthcare workers.
Okay. And then my final question is, I know that I think I think the department has a percent of critical healthcare workers that each facility needs to have vaccinated or have received the vaccine. And my question is that seems like that would be an important piece in vaccination or in vaccine allocation, as well as how quickly can our healthcare facilities get to that important percent of critical healthcare workers having been vaccinated. And I just wondered if you could speak a little bit to that.
Sure, that is, Madam Chair and Senator Nelson, those critical workers, that is completely dependent on the vaccine supply. And every acute care facility across the state has those same critical worker needs. And so that is why that is the first group that's being focused on. And so we're only able to provide vaccine as we receive it. And so we recognize that it is much less than what the need is, but we're allocating it as we receive it, and then the regions are distributing it, and the facilities themselves are using it to prioritize their most critical staff.
Thank you. I will just say it's a bit confusing how this 85%, this 85-15%, I understand how it's being calculated, but it's a little difficult to understand how it's being implemented without actually, we don't want anyone to have less of the vaccine available. But the point is, it's hard to understand how this 85-15 split is being implemented at the same time that we're saying that we need to make sure that those critical healthcare workers receive those vaccines first as they continue to do their work in treating COVID patients. And so
Senator Nelson, if I could just clarify, all of the vaccine, no matter how it's allocated, is going to critical healthcare workers. And it's all being allocated by region. So there is no vaccine that is not going to healthcare workers. 100% of the vaccine that the state has received is going to healthcare workers. It's just that as the regions are getting their vaccine, if a region has a higher social vulnerability in their region, they may get a few more doses than another region, but all the regions are getting vaccine only for healthcare workers. So it's not going someplace else. I just want to be very clear about that.
Sure.
Thank you.
Thank you.
Thank you, Dr. Erzman. We're going to move on to Senator Marty.
Thank you, Madam Chair. Dr. Erzman, I guess my questions relate to the preventing asymptomatic transmission. I get the vaccine. I'm protected from it, pretty strongly protected, but I could pass it on to others. We don't know yet, as your slide pointed out. My question is, between the two vaccines that are going to be available soon, when will we know? Is there likely to be a difference in that? I mean, we obviously, for the public health reasons, we can get a much quicker handle on this. If once I get the vaccine, I can't spread it to anybody else. But if we don't know that, when we do find that out, will we find out that maybe Pfizer's does prevent that and the Moderna one does not? Or are we tracking, in other words, enough of who's getting what vaccines that we'll be able to find that out?
Dr. Erzman.
Yeah, Madam Chair and Senator Marty, yes, I mean, there is ongoing evaluation that is continuing. So even though the FDA made an approval for this vaccine, the clinical trial aspect, if you will, hasn't ended. So what that means is they are continuing to evaluate those individuals in the subsequent months. I think one thing to keep in mind is that obviously we are focusing right now on Pfizer and then Moderna, but there are a number of other manufacturers that will be bringing vaccine online. And once all of those manufacturers are available, we'll be able to evaluate if a particular vaccine makes more sense for a certain population, or as you said, if another vaccine may have the ability to prevent asymptomatic infection, in which case that information would be used to recommend a certain vaccine over others. But at this point, with Pfizer as the only vaccine we have, we're starting to vaccinate. But it's an excellent point. The studies are ongoing, and ultimately we will be able to evaluate the vaccines against each other and how they perform in the population.
Thank you. And Madam Chair, one quick follow-up point, I guess, and that is health department messaging and so on. Until we know that the vaccine prevents asymptomatic spread, I hope the messaging is going out there to people getting the shots. We don't know if this prevents you from spreading it, because obviously healthcare workers will protect themselves, but what about their families when they go home? I hope they're getting the message clearly. Treat it as if you could still spread the disease, just that you're a little safer, because I think that's very important for controlling it. Otherwise, we're going to have people who, oh, I'm safe now, I can do whatever I want. And that could cause huge problems for the next few months.
Yep, Madam Chair and Senator Marty, absolutely. And that's why we are saying that we need to continue to mask and socially distance even as people are vaccinated.
Okay, thank you. Thank you, Senator Marty. Let's move on to Senator Matthews, Senator Abler, and then Senator Kiffmeyer. Senator Matthews.
Thank you, Madam Chair, and thank you, Dr. Erzman, for your presentation. My question is on the record keeping. I want to thank the administration. You're right on, so I do give praise when I believe right decisions are being made about. You emphasized strongly last week in the announcement that you're not going to push this in a mandatory fashion. That's an excellent decision, and I hope that's consistently applied throughout our society as this rolls out. But I want to help give you an opportunity to help explain the record keeping as people are researching this and digging into it. Is there going to be a special system of record keeping solely for this vaccine, or are you going to copy what is used for all the rest of the vaccine records? And then the only point that you mentioned about it on your slides was the vaccine card. As the incoming chair for civil law and data practices, that's going to be a focus of mine. So I'd like information on what information's collected on that. Does that look like? What's the card going to be used for in the immediate future? And what do you foresee it might being used in the long-term future down the road?
Madam Chair and Senator Matthews.
Dr. Erzman, yes.
So in terms of record keeping, the information that is provided back to the state is kept in our immunization information system. So it's kept in the same way that any other vaccine information is kept. There's not a special database or special system to monitor for COVID vaccine. In terms of the vaccine card, the intent of that is really so that individuals have a record of their vaccination, in part because this is a mass vaccination effort across the country. And so, typically you get most of your health care through the healthcare system, through a healthcare provider. With influenza, there are often workplace clinics and things. But we just want people, when they're getting vaccinated, to have documentation like, hey, this is the vaccine I received, this was the date, I've got this. But that's the only intent, is so that an individual has a record of the vaccine that they received, and so that it's not necessary for them to go to their healthcare provider to have that information. But I'm not aware of any other purpose for using the vaccine card other than to be providing people with the information themselves about their vaccination.
A quick follow-up, Madam
Thank
Chair.
you, Senator Matthews.
Is there any other vaccine that we issue a vaccine card for to the patient after they take it?
Madam Chair and Senator Matthews, well, actually, we used to do this. We had gold. Oh, sorry.
Dr. Erzman, your sound broke up a little bit. The last thing I heard was we used to do this.
Oh, okay. Is this better?
It's good, thank you.
Okay, I apologize. Yes, we used to give out, record cards to people. We've done that less now, but oftentimes you can get something from your healthcare provider to bring to the school or that type of thing. That's all that this is intended to be, is just to have a record, so the individual has a record of the vaccine that they got.
Okay, thank you. Senator Matthews, anything else?
No, thanks for the information. I'll keep watching this, and I'm sure we'll be digging into it deeper next session. Thank you.
Thank you, Senator Matthews, and I'm looking forward to your hearings. Senator Kiffmeyer, then Senator Abler.
Thank you, Madam Chair. So the question I have for you, Dr. Erzman, first of all, vaccination. So even after polio, a baby gets a polio shot, for a while they shed. They have that kind of contagious. So when you talk about asymptomatic spread after a vaccine, is it that kind of situation where you get vaccinated and for a while you have that, or is this a longer term thing? And the other thing is, I'm going to have about 3 questions. I'll shoot them all and then I'll wait. So the other one is, anybody who's already had COVID and has been tested and has those antibodies, are they considered vaccinated or how does that interact with being vaccinated if you've already had COVID and you have the antibodies? And people would really like a lot more information about the mRNA. Questions come like, is it safe genetically? I mean, they're just questions that come about that. And then the fourth one has to do with staffing shortages like we have right now, or in the education system when we get that far. So the benefit to these staffing shortages, I mean, that's kind of the benefit of having the vaccine is for them and for others they're around. So if you could address those 4 issues, or if you want to follow up later with an email, that's fine too. Thank you.
And Dr. Erzman, give it a shot. I was trying to take fast notes, but.
I take notes whenever you guys ask me questions. So I will go ahead. So in terms, I just want to clarify that in terms of when I talk about asymptomatic, what I want to clarify is we know that there are individuals who are infected with COVID, but who do not have any symptoms. And that's what I'm referring to. So it's not that people who have been vaccinated shed in any way. The vaccines do not even include the virus. So there's no shedding from the vaccine at all. It's just simply that if someone was exposed and to COVID and there was a potential for asymptomatic transmission, would that be covered? That's what we're looking at. And it's kind of a strange thing, but no, there's no shedding from the vaccine itself. Then in terms of antibodies, if you've had COVID, yes, you've developed antibodies. However, we don't know what the duration of protection is from that. And so we are recommending that even if you've had COVID, those individuals should be vaccinated. The recommendation right now is that if you, as we're in this phase where we don't have as much vaccine as we want, if you've had COVID in the last 90 days and you're a healthcare worker, we'd say just go to the end of the healthcare worker line. You know, let your co-workers who haven't had COVID get vaccinated first, and then you could get vaccinated. But absolutely, we want people vaccinated despite whether or not they've had a history of COVID. And the mRNA vaccines do not affect or interact with our DNA in any way. The mRNA never enters the nucleus of the cell, which is where our DNA or genetic material are kept. And the cell breaks down and gets rid of the mRNA as soon as it's finished sort of following the instructions and making that little protein piece. So there's not a genetic worry at all from this. And then finally, staffing shortages. Yes, we would anticipate that having healthcare workers vaccinated will make a huge difference in terms of staffing availability in both our acute and long-term care settings.
Senator Kiffmeyer, anything further? Otherwise, we need to move on to the pharmacist.
Just to follow up, I'm glad to hear all of those were good answers that I appreciate having, especially the staffing shortages. That is just a tremendous, intense benefit to everybody as well. I think the big thing is on that mRNA and that never enters the DNA. Would appreciate a link. I can go on the internet and search, but who knows? I'd like to make sure that what I have is from a source. So if you could provide a link on that whole never enters DNA, that whole mRNA that I can share with other people who have an interest in that. I would appreciate if you could get that to the entire committee. And thank you very much for your reply.
Thank you. And I just want to say thank you, Dr. Erzman. You've been really responsive to me. I know that you will be to other members of the committee. We appreciate your work, even if we want more information or maybe different information. You know what? I forgot Senator Abler's still in queue. Senator Abler.
Thank you. This Zoom thing is going to drive us all out of our minds after a while, but it's a good way to hear as best we can. I've been talking to some locals.
I got a little motion sick watching your video there for a few minutes, Senator Abler.
Oh, sorry. Yeah, I'll try to sit still. That's hard to do for some of us. But Dr. Erzman, thanks for all your work. I know that you were committed to this. I'm impressed with the organizational level you've been getting this all squared away with. You know, you and I have some history of discussions about how we might do things maybe a little bit differently. And just a comment, and then I have a question for you. I'm disappointed that the governor used hospital administrators to decide that restaurants shouldn't be open. And I think it's a false choice that we have no restaurants and bars and very limited gyms so the kids can go to school. I think there's quite a bit of compatibility with those. I asked the question yesterday at the other briefing, and it's just too bad that the places, especially that haven't gone to great extent of expense and effort to really upgrade their facilities, to have really good air systems and all that, have been not even given that opportunity. So I'm disappointed about that. That's just had to say that. And I hope that we can, I don't know, work together better on this. It's still also one-sided. But anyway, so my question about the vaccine part, I read in today's paper that some of the home care workers were very concerned and don't want to get it. Some of the seniors don't want to get it. Just so you know, I'm less confident in Pfizer's opinions than you are. They have a track record of not, you know, some of the other vaccines I think they've been inaccurate on the side effects. And you mentioned VAERS as in a kind of a laudatory way, and everybody knows that really hardly anybody uses VAERS. And so those are just predisposing things. But can you tell me, I guess I have just two questions. I don't know if we have time for both of them, but just the best you can, just comment about the concerns that these healthcare workers have and the seniors, but also can you just comment about where we are with nursing homes? In my opinion, it's squarely a responsibility of you all to get this squared away. And yesterday, tragic number of deaths and 60% were in nursing homes again. So the second question is actually more important than the first, but I'll give you a chance to respond to whichever. So thank you. That's all I have for questions.
So Senator Abler, was the nursing home question to Dr. Erzman about distribution or Commissioner Malcolm? I lost track.
Oh, is she still here? Well, let me just take only one question. Let's talk about nursing homes and how they're doing and why we're still having such high amounts. I don't see the battle plan as having succeeded. And people ask me, well, then you should be doing something. There's nothing I can do. It's not my department. Nobody asked my advice. We don't really have any input in that. And so trusting it to the state and the administration, the bulk of the deaths are still there. And so can you pretty much tell me why that is and why it hasn't gotten better with all the efforts that have gone forward and for whomever?
Okay, and thanks. I'm going to go to Senator Malcolm, I'm sorry, Commissioner Malcolm, and then we're going to move on to the pharmacy portion and let MDH go back to work. Commissioner Malcolm.
Thank you, Madam Chair. Thank you, Senator Abler. I just have to say, I think the improvements in long-term care are absolutely real. We've shared before the data that at the time the state's cases were beginning to spike from the middle of October through the middle of November, while the state was going up 73% in total cases, long-term care was going up 15%. The share of the deaths has been steadily declining, which is not to say it's not still a challenge and a problem. It is, but what's happening, the reason that the nursing home cases or this long-term care cases more generally are on the rise, I'll be the first to say, all of that great progress we sustained throughout the summer and early fall is eroding, and it's heartbreaking. But the reason for that is the prevalence of community spread. It is, and our data are still clear that the transmission is not happening within facilities as much as it is coming in from the outside. So, and we can certainly go over that data, Senator. I know you passionately care about it, but I think it does go, to the importance, and I know we have some disagreements on that, of these community-wide mitigation strategies to try to bring that overall case prevalence down.
Thanks. And just one final thing. So, Madam Chair, we had a hearing some months ago and talked about preventative measures in places at the nursing homes and assisted livings. And we were told that somewhere around 2/3 or maybe 3/4 were complying with what turns out to be a very rudimentary list, including a sign to say, wash your hands. Do you remember that hearing, Commissioner? Yeah. Could you, we're out of time now, but could you get to me the list of things that you expect a facility to be doing to comply? Because I'm also disappointed to hear that you don't know how some of them are doing, especially since they're still dying there. And so I'm sincere in this, and I don't And there's only so many things you can do, but this is where the people are truly in harm's way still, even though they're coming down. The percentages are still, the raw numbers are still very massive. And so.
And Senator Abler, get this back a little bit closer on track. I know that Senator Housley is going to have a long-term care hearing fairly early in next session. She and Commissioner Malcolm have already discussed that. So I think we can get some data, but I think there will be more public discussion. So I'm going to.
But the current list would be nice, Madam Chair. I'm done. Thank you.
That'd be great.
Thanks, Commissioner. Appreciate your work.
We're going to move on to Sarah Durr. She is with the Minnesota Pharmacy Association. The link between manufacturers and patients receiving the vaccine is played a large role by the pharmacy and pharmacists. So Sarah, welcome. Please state your name and talk us through how you've participated.
Thank you, Madam Chair and members of the committee. As the Madam Chair mentioned, my name is Dr. Sarah Durr, and I am a licensed pharmacist and I'm the Executive Director of the Minnesota Pharmacists Association. So MPHA represents over 2,000 pharmacists, pharmacy students, and technicians across the state. And so I work really closely with the pharmacists are administering this vaccine to make sure that we are doing it safely and effectively and that we're addressing our community need as much as we can. So today I want to talk a little bit about the role that we're playing in distribution of COVID vaccines, expectations that we have for the rollout, and what we think the first half of 2021 will look like. And I'll do my best not to reiterate anything that you have already heard today, so I won't do the Pfizer vaccine. So after working closely with MDH and the Minnesota Board of Pharmacy and the Waltz administration over the last 5 months, and this included our participation in MDH warp speed planning and training, pharmacists and pharmacies in Minnesota are ready to go. Earlier this week, pharmacists at hospitals, clinics, and different facilities were receiving their first shipments of the Pfizer COVID vaccine. And I know I had a lot of friends that were really excited and posted pictures of them holding the vaccine boxes because they're just very excited to finally get this in. And so we are beginning to vaccinate those healthcare providers, and pharmacists are helping with all of this. As mentioned, each vaccine is unique in the way that it is stored, handled, and administered. I won't go back over the Pfizer vaccine because we did cover that, but I do want to address Moderna vaccine as that is being approved as we speak. And that can be stored in a typical freezer. And so that's one unique thing that I think is really helpful for pharmacists. And we'll probably use the Moderna vaccine more frequently in the community pharmacy because it can be stored in a regular freezer and not that super cold. We are helping with the Pfizer vaccine administration as well. And we do use that spoken hub model to help pharmacies when we do get to that point of actually administering to the general public. There's also the Johnson & Johnson vaccine trials that are coming out, and they're testing both a 1 and 2 dose regimen. And it's expected that it will be stable at refrigerated temperatures. So that's another advantage that that vaccine may have once we see that. And they were going through phase 3 trials in September. So we're waiting to kind of hear where that one is going to come out. There's also specific administration requirements for the COVID vaccine products. And so that's something that pharmacists are very in tune with. And we're helping physicians, nurses, and nurse practitioners and others to understand how to administer this vaccine if there are any specific questions. And we talked a little bit about Pfizer's and how that can be administered and needing to be 21 days apart. Moderna will be actually 28 days between the 2 doses. So a little bit longer time period. And I think that's why that vaccination card is so important, so that patients know when to come back to get their second dose. Let's see. I did want to make a note that the public should not be vaccinated until phase 3 because we really need to take care of our healthcare providers. So if you are talking to your constituents and they're talking about going to the pharmacy to get their vaccination, let them know to wait until phase 3. We may have some people in the public showing up at pharmacies asking for the vaccine at this point, and we don't have that available at the community pharmacy level at this point. So I think if there's a message I can leave with you today is the vaccines that are approved by the FDA are safe and effective and can be trusted. Minnesota Pharmacy is ready and is already administering COVID-19 vaccines across the state. And finally, we are all in this together, so everyone needs to participate. Get your vaccine, help us create herd immunity. I know that's a huge challenge we're gonna have with the general public. And again, we just appreciate the leadership of Senator Benson and the members of this committee, as well as our partners at MDH. I'd be happy to discuss any questions you may have, but just know that MPHA is working hard to get messaging out to the public, to make sure that they are aware that the vaccine is safe and we need to get the vaccine. And we're also working closely with our pharmacists to make sure that they are completely prepared, are trained, and ready to give the vaccine. So with that, I can turn it back over to you, Madam Chair.
And Sarah, I'm going to try to keep this short. You gave a very complete, succinct presentation, so you should do training for people who come to legislative hearings. But I do want to note this committee, and I'm so grateful for the foresight of the people we work with, gave permission for Minnesota pharmacists to give the COVID vaccine. I know there was a waiver at the federal level, but thanks to some of the work that your team did, we got that across the line before the feds did that, because we know you're important partners. So thank you for that. You talked about it's not going to be available to the general public. And I don't recall, did you talk about when clinical trials for children to receive the vaccine are going on? I think that's important for the public to know.
I am not sure exactly when the children's clinical trials will be happening. I know that they'll be coming up likely in the first quarter of 21, but I don't know an exact date that they're looking at. I don't know if anybody else on the call, I think she dropped off.
And it's another awareness that children are behind the adults in the clinical trial rollout. So we're looking at July, maybe August for children. Does that seem like a reasonable timeline?
Yeah, I think it'll be before next school year, but it'll be right around that time would be what I would guess.
Okay. Thank you. And I'm happy to take questions from members. I see Senator Nelson has her hand raised. I'm not seeing any other hands.
Thank you so much, Madam Chair. Actually, my question was for the Commissioner and Ms. Erdsman, Dr. Erdsman, if they happen to be there, or if they can contact me directly. It has to do about a definition.
Yes, Senator Nelson, they are not here, but Lisa's here. And so actually just have you reach out to Lisa or the Commissioner directly, okay?
Senator, it's Lisa. I'll send you an email.
Oh, if I can just ask the question and get it answered, which is just the definition on acute. It was that vaccine allocation discussion that I had with the Commissioner, and something about acute care was part of determining that. And I just wanted to know how acute care was defined. And you can get to me offline. I won't take up the committee's time for that answer right now.
Okay.
Thank you, Senator.
Thank you very much. Any questions for Dr. Dare? Okay, members, I hope this information proves valuable to you as you communicate with your constituents truth about the vaccine, so people continue to make voluntary informed consent decisions about this vaccine. We need them working with their regular care providers to make the right decision for their family, but it's going to be a while before the general public gets this vaccine. And members, I think this is our last meeting as our committee thusly structured. I saw Senator Draheim came on video. Did you want to make any comments, Senator Draheim?
Oh, just Merry Christmas.
And Merry Christmas. However you celebrate this holiday, I'm grateful for our collaborative work and for your dedication to the people of Minnesota. So thank you all. And Senator Wicklund, it's good to see you. Thank you all. I wish you peace. We have gone through a lot of stress this year. Let's look forward to the turn of this decade to the next, and we will see you all in January. That's our plan right now. So thank you. And with that, our meeting is adjourned.
you.